Let's shine by seeing the best in all of us and by treating you here, right in your hometown. Let's look out for each other. Let's stay healthy. Let's shine together.
Hi, I'm Sharrie Harlin Davis, program host for Let's Talk Together. And in today's episode, we are going to talk about colorectal cancer screening and awareness. And as we start today, we will have a short video from Dr. Sylvester Osai.
Well, a lot of people think, colonoscopy is not necessary. It is maybe they don't have any person in their family that have colon cancer, so because they don't have a family history, they feel like they don't need the colonoscopy. Sometimes some people can feel that they're too young to get a colonoscopy. Maybe they might be 50 or 60 and they feel like they've been healthy all their life and they just don't need that. Some people may be embarrassed, when they understand what colonoscopy is, that someone is putting a camera through the bottom and looking into the colon. So might make them feel embarrassed. So there are several reasons that sometimes it could be that they feel the prep is bad, is the prep is difficult to take, and they might not be able to take the prep well. Well, first off, especially for patients who feel like, they're too young to get a colonoscopy, I would say, you're never too young. The recommendation now is to get colonoscopy if you're over 45 years old, both men and women, because, it's very important to diagnose colon cancer early, and colonoscopy is a very good tool to diagnose this. Colon cancer is the second leading cause of cancer death in both men and women. So if you can screen for it and find it in the very early stages, that is life-saving. Colonoscopy will find polyps, and polyps are kind of the earliest abnormal growths in the lining of the colon. And so if you find this with colonoscopy and you take them out, that would reduce the risk of colon cancer. So patients don't need to feel that they are too young. Some patients think they don't have any family history. Most cases of colon cancer are in patients with no family history. So the fact that you don't have anyone in your family with colon cancer would not be a reason not to get it. There's also the misconception that the procedure is painful. That is not really true. We do colonoscopies here with sedation. So in the room, you have an anesthesiologist who's providing some sedation. So the patient is sleepy and they don't really remember the procedure. They remember coming to the hospital, going into the room, but really that's as much as they remember. So they're not in pain during the procedure. Also, some patients feel like, this is an embarrassing procedure, but I would say that shouldn't stop them from getting it. The doctors and the nurses that do colonoscopies, they do that every day. And, they're there to do their job, to take care of the patients. And, they take care of a lot of patients. So that shouldn't make anyone embarrassed. There are different preps that are used for colonoscopies. One of them is a large volume prep. Go Lightly is a 4-liter of fluid that you drink, and it helps clean the bowels, clean the intestine. There's lesser volume prep that we really use now. They include Docolax pills that you take several times in the day before surgery, and also Miralax. Sometimes there's even Gatorade that you take. So there are other preps that are not as much volume that you would take the day before. We have times that we give this prep, and most of this starts late in the afternoon or evening time. And the idea of the prep is that it would clean your bowels. So the patient is going to have diarrhea, go to the bathroom several times. That could be the part that is unpleasant for patients. Running to that bathroom, there's some spasms in the rectum with having those forceful stool. But usually after the first few ones, later on as the bowels get more cleaned up, patients don't have as much discomfort as the initial time. If patients don't spend very much time when they come in for colonoscopy. So when they come in, they get checked in the outpatient surgery area, and then the nurse will bring them into a room where they change to the hospital gown, and they get an IV placed, and we'll look through their medications and make sure everything is ready for the procedure. The procedure itself, patients go into the room. The anesthesiologist will give the patient some sedation and get them sleepy, and then the surgeon or the endoscopist will perform the colonoscopy. The procedure itself lasts between 30 to 45 minutes. So it's actually not a very long procedure. So that's another bit. Some patient think that it takes all day. No, it doesn't last very long. And then after that prep, the patients go over to the recovery area where they wake up more from the sedation, and then they go home. So patients can come in for a colonoscopy at 7:30 and be home, before 10 o'clock. Yeah, usually for just the screening colonoscopies, especially for patients with no family history, they usually start at 45, and this involves both males and females, starting age at 45. It used to be 50, but now recommendation is to start earlier because we're seeing colon cancer in younger patients. Patients in their 20s and 30s, we're starting to see a case of colon cancer. For patients who have family history of colon cancer, they should start screening earlier. So some of those patients could start at age 40. Other patients that should get colonoscopies are patients who are having, abdominal pain with unknown cause, rectal bleeding. Those are patients that should get colonoscopy. In addition to finding colon cancer, colonoscopy could actually also diagnose other colorectal abnormalities, like Crohn's disease, irritable bowel syndrome, another form of colitis. I would just say that colonoscopy is a very effective screening tool. It saves life. Everyone above the age of 45 should get one. And after the first colonoscopy, if everything is fine, no large polyps, you really don't need to get another one for 10 years. And those who have family history of colon cancer should actually start earlier than 45, so say age 40, because we're seeing colon cancer at earlier ages. So if there is a screening tool that can find small polyps, which are just abnormalities that are not yet cancer, that would prevent the risk of them developing into cancer, I think is very important for people to undergo that screening procedure because it can save life.
And welcome back. And now we have our second guest, and this is Dr. Naeem Raza. And you're with internal medicine?
Yes, I am in the Reed Hospital Internal Medicine and Gastroenterology Department.
Well, welcome. And before we get started, tell us how you came to Reed.
I have worked before in Pennsylvania, where I finished my fellowship training. And I joined Indiana University Hospital for 5 years. And then I moved here, Reed Hospital, with my family. And I am working in Reed Hospital for last 4 years.
Well, welcome.
Thank you.
And explain, since this is colorectal cancer awareness, what are some of the biggest things that we should know? That I understand it's the third most common cancer. Can you explain some more?
Yes, first of all, I like to thank you and your team for letting me part of this very noble cause and conversation.
Well, thank you.
Where we can increase the awareness and improve the prevention for colon cancer. Colon cancer is the leading cause, one of the leading causes of the cancer and mortality, death from cancers. The most important part I did learn from my experience that it is most part of that is preventable cancer. You cannot beat the prevention. Also, if you diagnose in the early stages cancer, you can treat it very successfully. That is why we like to stress awareness in regard to the prevention of the colon cancer, and today we will discuss in detail different methods available to prevent the colon cancer.
And with some of the things with the occurrences of cancer, what's like some of the number one things that you see? Or let's look at risk factors.
So most important risk factor which we cannot stop is the age. That is why recently most of the societies, including our Gastroenterology Association societies, all of them, United States Prevention Task Force and American Cancer Society, they all agreed to start screening at the age of 45.
Okay.
So best tool is to make sure we are all aware, we are communicating with our physicians. At age 45, we start screening for colon cancer. Other risk factors are mostly related to the genetics, some of the medical conditions, including inflammatory bowel disease, where we need to start screening earlier stages. Easier way to remember or think if in your family history there is risk or there is a history of colon cancer, especially in the first degree relatives, we need to talk to our physicians where we may need to start screening for the colon cancer at the early age.
And that's with hereditary.
Hereditary,
right?
yes.
What about, can your diet affect?
We recommend, in general, healthy lifestyle, eating healthy foods, which includes more fresh fruits, salads. It also not only helps to decrease the colon cancer, improves the colon symptoms also, and also increase in physical activity and staying healthy. Those things helps a lot.
So when I brought up the diet, those are things you can change. So things
Yes.
that you can't change were like the family history or
Absolutely.
the inherited that syndrome. So do you tend to speak with families that possibly if are you more prone if like a relative had
Yes.
colorectal cancer?
Yes, we discuss with our patients based on their family history of colon cancer, and in some patients, they have genetic conditions where they have more other types of cancers, such as ovarian cancers, breast cancers, and they also have sometimes the genes which tells us they have more risk to develop colon cancer. Again, as you mentioned clearly, some of the things we cannot change, family history and genetics. But by increasing awareness and talking to our physicians, we can start screening appropriately at the right time and do screening as indicated. This can surely prevent and early diagnose if there is any risk for cancers in this patient, and that can make significant improvement in their prognosis and outcome.
Another factor was type 2 diabetes.
Yes. This is something we are working as whole nation, focusing on our lifestyles, on dietary changes. We are dealing with this dilemma. It can cause risks for the cancers, as you mentioned, and also many other medical conditions, fatty liver and other problems. We all need to work closely with our primary care physician.
Now, when you were saying like 45, it seems like, did that number change? Or had it been, has it always been 45, or had it been a different age group, or have you lowered it?
Yes, we were working for a long time for the age 50 and plus. Recently, we have noticed over the period of years that we are finding more cancer in younger age.
Okay.
That is where this guideline was discussed and implemented by all the major societies to start screening age 45. We also noted in certain races, such as African Americans, we have more risk for getting more aggressive cancers or earlier cancers. That is why we want to focus across the nation with everybody to discuss with their primary care physician their individual risks, and age 45 for everybody to start screening in these patients.
And it says get screened every 10 years.
Yes, it is indicated to screen every 10 years if you do not have any precancerous polyps or do not have any cancer. If you find any of those conditions, precancerous polyps or cancers, then screening years might change.
Then one of the things that we also can see, if there's how would you know something, one of the factors such as the signs and symptoms? What?
Yes. So screening means age 45 if you do not have any signs and symptoms. That's where we call them screening or prevention. But if you have signs and symptoms, you may need to be checked earlier. So what are those symptoms which patients may see? If you are seeing some significant change in your bowel habits, stool color, frequencies, size, your normal bowel movements, suddenly you cannot control bowel movements, diarrhea, constipation, the symptoms which are not making any sense. Patients are seeing blood in the stools. I have seen many times patients feel that could be hemorrhoid. There is a possibility that blood you see could be hemorrhoids, but it needs to be checked, needs to be discussed with your primary care physician and probably with gastroenterologists. If you're losing weight with that, which is also concerning symptoms, discussing with your physician, and if there is any family history related to the GI symptoms, especially in this regard, needs to be reviewed with your primary care physician and may need colonoscopy, screening, or examination sooner.
Okay. And when you were saying with the as a just regular person, when you're saying that, how would I know about with the blood? So if I see when it says rectal bleeding or blood in your stool, that's a sure sign that I need to call my doctor,
Absolutely.
my primary care doctor.
Absolutely. It is always a good idea to discuss with your primary care physician. Blood will be seen mostly as bright red blood. It can be seen as a dark or black colored stools also. It can happen sometimes painless bleeding. They just see the blood in that. Sometimes it comes as a painful bleeding. In all these conditions, we should not take that as lightly as self-diagnosis. We should also communicate with our primary care providers immediately.
And I'm trying to think of how's the best way, because I can assume that when you'll see blood and you go into a panic.
Right. The best way most of the time when you see the blood in the stools is to pick up a phone, call your primary care physician. Most important thing in that situation, primary care physician can assess, is this an active and severe bleed which needs immediate evaluation through emergency room or through as an outpatient within 1 or 2 days. They can assess, no, it is something which can work up with colonoscopy, with communication with the GI physician within a few days or week. So those idea that how soon the procedure and what is the right step to be taken will be done in coordination by discussion with your primary care provider.
Okay. Another thing, the cramping or abdominal pain.
Yes. Cramping and abdominal pain is a frequent symptoms in our patients with the bowel symptoms, such as diarrhea, sometimes with the constipation. It can happen in patients when they have colon cancer, but it can happen most of the time with irritable bowel syndrome, inflammatory bowel disease, and other conditions in the abdomen. Most important thing is to talk with your physician. If you have cramping and abdominal pain with significant uncontrolled diarrhea, you have a bleeding and you have a fever, that might need emergent communication with your primary care physician or through the urgent care or emergency room. But if you have just mild cramping and abdominal pain and it is a chronic condition which is happening over the period of weeks and months, talking to your primary care physician and gastroenterology specialist to discuss how to diagnose the right problem and how to address is very important.
And weakness and fatigue?
Weakness and fatigue indicates your blood loss is leading to anemia, low blood count. And when you have a low blood count, your body does not have sufficient blood to carry oxygen to your brain and the body tissues. And you are developing symptoms of fatigue, weakness, dizziness. Sometimes in severe bleeding, you can even fall because you lose blood pressure when you stand. So it is important not to take this symptom lightly and discuss with your physician where they can check your blood count and make the further diagnosis.
And another thing is the unexplained weight loss.
Unexplained weight loss, it is very important to address that appropriately. This is always concerning in our mind. We look into the reasons where you have malabsorption, you are not able to digest your food, or you have some kind of cancer or malignancy, some other serious conditions. So it is important to tell your physician and review the cause.
And that's a hard one. On a different note, when you're saying unexplained weight loss, like, I'll take that, but
yes.
But
yes.
I know that as part of the
yes,
process.
Absolutely.
That we need to know where that's coming from.
Absolutely, it is important to know.
So, tell us some of the preventive screening. What can be done?
Among all the groups of physicians and organizations, there is consensus that colonoscopy is the best method for the screening and prevention of colon cancer. Colonoscopy is a technique, a method where you can not only examine, visualize the whole colon where the cancer occurs, or early stages of the cancer comes, which we say polyps. Polyps means small tumor, which initially is benign, and then it develops some precancerous features and slowly it develops to cancer. According to our research and guidelines, it takes 5 to 10 years to develop cancer from polyp. So that is why colonoscopy helps to find that small growth. It also helps to remove that polyp. So this is very important. You are achieving both by diagnosing and removing, bringing the risk back again to normal in those patients by taking those growths away from them. There are other techniques available also to do the prevention and to diagnose precancerous conditions. Those conditions, most of them are non-invasive. Colonoscopy is an invasive method where you prepare and you bring and you do the test. Non-invasive techniques are stool tests. There are simple stool tests. We check for blood in the stool. Now we have a stool DNA test, which can also check the DNA if there is any precancer or cancerous tissue in the colon. That test also checks the blood plus the DNA both. That is, and then there are radiological tests, CT scan, which can take a picture like a colonoscopy, another test which is available to screen for colon cancer.
Now, when all these tests that you mentioned, they come to your office?
Yes. So most important thing we found in our patients' interactions that you work with the patient. When you provide them thorough discussions, these are the tests, and help them to make a choice, patients generally comply. So we have a problem in our nation. We noticed we have tests available. Compliance is an issue. One of the reasons of the compliance is not involving the patient in decision making and not educating them sufficiently what are the available tools and just telling them do this thing. So this is important. We share with the patient all the information, help them in making a decision. Colonoscopy is done mostly by certain physicians who are trained in this procedure, such as we are doing it here by gastroenterology group of physicians and our general surgeon. Other methods such as stool tests can be done by their primary care physician and the gastroenterology clinic. They can be ordered easily by them, and then labs send them the specimen, helps them to collect the specimen and run that test. Stool tests are not as perfect as colonoscopy, and also if your stool test is positive, that could be positive by blood from hemorrhoids or by DNA, you still need to go back to get your colonoscopy done, because that means there is something which needs to be looked at it, it needs to be checked at it, maybe removed again. So that will add back the need for colonoscopy if stool test is positive. Stool tests also have some limitation. Not everybody can go through the stool test. Even the stool test guidelines suggests there's certain age requirements. And if you have history for polyp and cancer, you cannot do the stool test. You have to follow with those patients screening and prevention by colonoscopy methods. The radiological test needs to be ordered. They can be ordered by primary care physician and by the gastroenterology, anybody. But those radiological tests are difficult to get insurance approvals. They generally recommend to choose between the stool test versus colonoscopy first.
And probably one of the biggest misconceptions are drinking the PrEP. So
yes, that is one thing I always tell my patient. If I find a better solution, I would not be working hard every day. I'll be sitting on a beach. So that night before, they have to help us. Our goal is to examine carefully, clearly the whole inside of their colon. For that, they need to help us to prep. And by that, they need to drink either the bowel prep, but right now, we have other options, which including tablet options. We have 2-3 options from the tablets from different drugs, which works also as liquid bowel prep. But in all of those options, we still need to drink plenty of water to stay hydrated and get those either tablets or liquid options to work.
So, and that's probably the biggest thing when you hear a person saying they're having a colonoscopy, just to get ready for it.
Absolutely. They're taking a day off also from their work and preparing for the procedure. But when we involve them in the decision making and share with them how important this test is in preventing the cancer and early diagnosis, they all agree that it is worth it.
Definitely worth it. We want to thank you for joining us today on Let's Talk Together. Thanks for joining us, Dr. Raza. We really enjoyed this.
Welcome. Thank you for having me.
And thanks to our audience for joining us today on Let's Talk Together.
Let's shine by seeing the best in all of us and by looking out for each other. Let's stay healthy. Let's shine together.